So Dale Cooke is an accredited practicing dietitian with Diabetes Queensland. She writes articles for their publications and facilitates education programs for health professionals and people living with diabetes. Dale trained as a dietitian 29 years ago when her husband was diagnosed with type 1 diabetes. So she understands the day-to-day issues of people living with the condition and their carers. Dale is passionate about helping people improve their health by making sustainable changes to their diet and lifestyle. Dale, thank you so much for joining us.
No trouble, Lindy.
Now, when you agreed to speak with me, I put a call out on our groups for questions, and you were white hot. Inundated, which I guess is a little bit sad because we clearly means we need a lot of information, but it's also great because people are enthusiastic about taking ownership of their own health journeys. So we were inundated with questions from our socials. So we have much to cover today. But let's just start at the top in the very beginning. So can you tell us what is diabetes?
Diabetes is a condition with elevated blood glucose levels. And it depends on what type of diabetes it is as to why that occurs.
Yeah. So what is the difference between type 1, type 2 and gestational diabetes?
Type 1 occurs when something happens in the body to stop the pancreas from working. Generally, it occurs when you have to have a genetic predisposition for it, and it often occurs in young people, so people under 40, and quite often in children, and it happens very rapidly. The body turns on itself, and it's an autoimmune condition, so the body will actually destroy the cells in the pancreas that produce insulin. Having said that, there's a lot of people who are over 40 who are also diagnosed with type 1 diabetes. These people are called latent autoimmune diabetes. And this is where it takes a little bit longer for it to occur. It's not like kids, which can happen really rapidly over days. It can happen over weeks, months, and maybe even longer, we don't know. And basically, the body destroys its own beta cells in the pancreas, and no insulin is produced. The only treatment for type 1 diabetes is insulin. Type 2 diabetes is very different. It's very common in older people. As you age, it's more likely because the body starts to wear out for a start. So, and we don't pick up on that quite often. We just assume, going to the toilet a bit more, or I'm feeling extra tired today, I'm getting old, blah, blah, blah. But then suddenly diabetes is, type 2 diabetes is diagnosed, but you could look back and go, oh yeah, I can see the progression. And what happens first is there's insulin resistance. Of course, you need some genetic predisposition initially, and that could be through ethnicity, or it could be through the fact that your mum had gestational diabetes. So when you were growing in the womb, you were bathed in a high insulin environment and higher blood glucose environment potentially. The ethnic backgrounds which are higher with type 2 diabetes or are more likely to develop type 2 diabetes include Aboriginal and Torres Strait Islanders, Maori and Pacific Islanders, people from Africa, from the Arabic types of countries, Eastern Europe, almost everywhere but the white Caucasians.
Right.
So it's Southeast Asia, South Asian countries. So the majority of the world is prone to diabetes, which is quite sad. What happens first is there's insulin resistance. So your body is made up of millions and millions of cells, and the glucose isn't getting into the cells. Now, this mechanism is something that we're not exactly sure why it happens. Potentially, it could be because there's fat throughout the body's tissues. Some people store their fat on the outside like a selvage, whereas other people store it sort of a bit like Wagyu beef. It's all through the tissues.
Good example.
Yeah. So dietitian example food. So anyway, the insulin doesn't allow the glucose into the cells, and that's called insulin resistance. So this makes the body work harder. At this point, you might sometimes feel tired. You might have a little bit of high blood glucose after a meal. So you might be going to the toilet a lot more to pass the glucose out in the urine. You might be feeling thirsty. And then you get to a point where the pancreas is working so much harder to produce more insulin to counteract this insulin resistance, and then the pancreas starts to wear out. And when that happens, there's not enough insulin being produced, and so the body can't manage and blood glucose levels go high. And that's when a lot of people are diagnosed at that point. So that's type 2 diabetes. Now, gestational diabetes is the appearance of type 2 diabetes during pregnancy. And it's because it's hormonally driven, because the hormones of pregnancy reduce the effectiveness of insulin. So there's natural insulin resistance. And it's not good because there's complications for both mum and bub if it isn't managed well.
Right. You raise a number of things there. And I will refer to myself because I'm still learning myself. And I was, they thought I might have had gestational diabetes, and they tested and they said, no, you're okay. And then I had a 12-pound baby. But also the insulin resistance. So, I guess the testing, let me go with the testing first. So I knew that I was potentially, that was 26 years ago. So I knew that I was potentially on a pathway to that. So I used to get myself tested every year. For the last 25 years, it's been fine. At no point had anybody said to me you're pre-diabetic or anything like that. Is the testing sufficient to pick this up if you're pre-diabetic or you're insulin resistant?
What sort of tests were you having? Were you having just fasting glucose test?
Yep, just fasting glucose and normal bloods.
Yeah, that's just telling you what your glucose is overnight. It's showing that because we store a little bit of glucose in our liver for occasions when we're not eating, sometimes in diabetes, the glucose leaks out of the liver inappropriately. And so if you had your blood test and you were fasting overnight, it's showing that your liver is fine, but it's not telling you a whole lot about your insulin production or whether your body is managing. The oral glucose tolerance test is a better test if you're worried about diabetes. And it comes back, I'm just trying to get my mouse to work, it's not working. There's a really good guidelines on the oral glucose tolerance test.
Yeah.
It will pick up whether you have pre-diabetes or not. So if so the fasting glucose test is pretty it'll tell you yes you have diabetes, no you don't. Whereas the oral glucose tolerance test is you have a fasting test, you drink a set amount of glucose, and then they check you at 1 hour and 2 hours. Yeah. And so they can see whether you have what is called, I'll spit it out in a minute. It's glucose intolerance.
Yeah.
Or what's the other one? Glucose intolerance, or it's basically the fasting level isn't good. Right. Impaired glucose tolerance, impaired fasting glucose. So that's when you're pre-diabetic.
Okay.
So that's where, you've got pre-diabetes, it's time to take action. Or even before that, you can take action to prevent getting the pre-diabetes. If you've got the genes, if you've got the family history, it doesn't mean it's absolutely inevitable, but it means that you can put it off for longer if you work hard on healthy eating, regular physical activity, stress management, and do all of those things.
Yeah, exactly. And I think, at no point has anybody ever mentioned pre-diabetes. I didn't even know there was such a thing. So I'm glad to see that there at least is an area where it's a kind of reprieve, right? It's like somebody saying to you, righto, if you don't take ownership now, you're going down the wrong path. So it's good to see that that's a part of that now. So we talked about, so I guess we touched on a little bit, what causes type 2? What are they? What are the causes?
Well, the things that you can't change are your genes,
yeah,
and your ethnicity. You can't change your age. As you get older, the body just wears out a bit. The pancreas just doesn't produce insulin like it did when you were a young whippersnapper, so to speak. But there's a whole raft of things that you can change, and one is whether you exercise or not. Think about it as glucose being a liquid. When we're having flooding rains and they're letting they're letting water out of the dams, and then we have a high tide. We end up with floods everywhere. If you're not exercising, your tide is up all the time, and then every time you eat, you're getting a new flush through of glucose. Whereas if you're exercising, you're taking the tide out every time you exercise, so you don't end up with the flood. So exercise is good, being active. The other thing is considering what you eat. So I come from a health at every size perspective. So and an intuitive eating perspective too, in that there's nothing that's completely off limits, but you have to be aware of what you're eating, how often you're eating, and why you're eating, because a lot of people will eat for comfort rather than hunger or enjoyment even. So being aware of what you eat and making sure you're getting all the healthy stuff as well as some of that other less healthy food. And things, some people can have conditions where they might, for example, get pancreatitis, which causes damage to the pancreas, or they might need steroid treatment, and that causes increased blood glucose levels. So all of those sorts of things you can't really control. You just have to go with the flow.
Yeah. And while we're on that, I'm sure you're familiar with Dr. James Mukey, the ophthalmologist and blindness prevention pioneer. Whether he's got a keen interest in diabetes as well because of sight. Now, he's just recently claimed that a simple way of looking at diabetes is a carbohydrate intolerance. So therefore, the treatment must be a carbohydrate restriction. Would you agree with that?
Well, it's a different way of thinking about it. I personally see it as from a bigger perspective, because a lot of people have eating issues, and so just saying cut out carbohydrate doesn't fix those eating issues. It can exacerbate them, in fact. So it's the main thing in our diet that influences blood glucose levels is carbohydrate, but our body will turn fat and protein into glucose if we don't have that. And the issue there is that it's really hard to stick to a very low carb diet. People just can't stick to it. They don't like it. It's not our common way of eating. Now, our way of eating now, if you follow a typical Western diet, it's not actually very healthy. Only 7% of Australians eat the 5 serves of veggies that we recommend every day for good health. So
it's interesting you say that, because when I was first diagnosed, you know what, I wasn't I was absolutely devastated, but I was equally not surprised, right? So I said I was in an ambulance because of back issues, and he took my bloods and he said, "Are you diabetic?" And I said, "No, what are you going to tell me?" So then therefore it all started. But so when I saw my GP to start the process of understanding more about it and medication, I went back after 3 months and she said, "Look, it's going to take you 12 months to get this sorted out. You know, it's very complicated, it's complex." And I sort of left and said to myself, well, that's not going to happen. It's going to be fixed in 3 months. And by the time I go in for my next HbA1c blood test, it'll be, down. And it was. I went in and it was 5. But I saw my diabetes educator not long after that, and she said, "That's fantastic, Lindy. Now, is that sustainable?"
Yeah. Well,
I said, yeah.
Two things happen. One is diabetes is progressive.
Yeah.
There's lots of research on at the moment to work out, is it, if we do we don't use the word reverse, we use going into remission. But if we go into remission, how long can we go into remission? I use the analogy of, those in the shopping centres, those travelators that you're going up and down, you stand on and everyone zooms along. Well, everyone is on their own travelator going at their own rate. And you can do things like change your eating, do regular physical activity, lose weight, take medication, and you're stepping back on your travelator. But essentially, just because you're aging, you're going forward. But everyone's going at their own speed, and yours might be super slow, but other people's might be super fast, even if they do everything right. And that's where people aren't comparable. You can't say, "Oh, this worked for me, so you should do that."
It's amazing, isn't it, how that is so true. Mm-hmm. And, I've been in all these Facebook groups, which I find incredibly helpful, but we all have completely different experiences. What you eat, when you eat it, the time of day, what you eat it with, when you have your medication, all of these things impact just me, not just the guy next to me or whoever else. So that's why I think people are really struggling to get their head around it. So, which is why this is so incredibly helpful. That's brilliant. Okay. So I might go into a Facebook question now, one of the groups. So she said, "I'm keen to learn why metformin is the go-to medication that is prescribed first when others like, I think it's Jardimet, is that right? Seem to be better tolerated by most, particularly with less digestive issues." How do you feel about that?
Well, metformin is one of the oldest medications for type 2 diabetes. It's been around a long time. It's cheap and it's effective. We know a lot about it. We know the side effects and so forth. So that's why it's the first line medication. Now, Jardimet is actually a combination of metformin and Jardiance. So there's lots and lots of families of medications. Jardiance is an SGLT2 inhibitor, which means that if the glucose gets too high, it spills over into the urine via the kidneys. So the Jardiance just does that, whereas metformin, it works on if there's any leakage out of the liver overnight, particularly, it plugs up those holes to stop the leakage, slows digestion, so you're not eating as much, and some people can lose weight on metformin. And it also reduces the insulin resistance at the cellular level. So metformin has a threefold effect, where Jardiance has just that single action, but they've put it together as Jardiamet. So because diabetes is progressive, you usually start out with diet and exercise, and a lot of people don't do too much. Some people do wonderfully, but other people just kind of go, "Give me a pill, I'm too busy." So then they start with metformin, and as things progress, they wait and see. Usually HbA1c, which is the 3-month blood test, comes back and things are lowered, but over time things will change. And of course, if you hit a stressful period in your life, or if you're ill for any other reason, so pain or sickness, put your blood glucose up. So does stress. The body's producing or releasing extra glucose so that you can use that in the stressful situation to either run, so the flight, or to fight. The body's not thinking, oh, but I've got diabetes, so I shouldn't do that. So
yeah, one of my greatest, I guess mistakes, for want of a better word. Yeah, it's true. I mean, stress and chronic pain. I just see that happen when I'm in that state. So yes, it's a whole package, isn't it? It's diet, exercise, making sure that we take the time for ourselves. So, all right. So going back to the carbohydrate, and obviously that has its own set of challenges because the Western diet does include that. But I think we can work hard to reduce the amount. But what other advances in diet? Because clearly we used to talk about, and the only thing I did know that was that sugar and refined sugar was the issue. Now that we know the carbohydrate, which turns into sugar, what are the other advances, or what else have we discovered recently in terms of diet that affects our blood glucose levels?
Well, if you look from the perspective that carbohydrate is equal to starch plus sugar, then both starchy foods and sugary foods affect our blood glucose levels. A lot of people don't understand that, for a start. But it's also the amount that you have. So if you look at the Australian Guide to Healthy Eating, which is the pictorial guide for the Australian Dietary Guidelines, it shows you the 5 food groups, and all of them contain carbohydrates. If you were to cut out carbohydrates, you would lose basically all of your fruit, all of your grains, but parts of the others as well. So it really, if you go super low carb, like keto carb, that's going to influence your nutrition to a degree that you're going to be deficient in some things if you aren't really careful. But if we just look at the bottom of the guide, it shows you the sometimes foods. It says sometimes in small amounts. These are all of those foods that are high in added sugars, high in added, often saturated fat, and high in salt, as well as alcohol. Now, if we just reduce those foods, but they're the foods that we like to eat, but if we reduce them considerably, our carbohydrate intake would drop to about 45% if we're getting a balanced diet, but still eating what is recommended from the other food groups.
Right.
So you can have a moderate carbohydrate diet by just reducing as much as possible those sometimes foods. But if you're one of those people who, if I say do not have this, and then you go out and you have to have this, then saying that that's where you say sometimes in small amounts. Yeah. And then it's okay. A lot of people will say, okay, I'll cut out grains and cereals, I'll cut out fruit, but I'll eat my chocolate and my soft drinks still. And that's kind of, it's a lose-lose situation.
Counterproductive, huh?
Yeah.
Yeah.
The other thing to think about is glycemic index. Now, it's not a new concept, but it might be new to people with diabetes. And it's a measure of how quickly a carbohydrate-containing food is digested, and then the blood glucose rises. So choosing at least one low GI food with every meal or snack is a good way to go. And that's where you look at if you have something that's grainy, it's a whole grain. If you are having fruit, you on its own, you'd look at a low GI fruit. So apples, citrus, stone fruit, berries. If you wanted something that was high GI, you would just have a smaller serve or have it at the end of a meal. So that's where we need to think a bit flexibly. For example, watermelon is a typical high GI food, but there's not much carbohydrate in a small piece of watermelon. It's just the fact that we tend to eat a large serve or eat them in isolation. So keep the serve small and keep it, eat it mindfully too, so you are enjoying it. Don't just wolf it down, because we tend to wolf things down in front of we've got our phone, our computer, the TV's going. We don't taste the food. We don't, it's just, did I eat that? It's okay.
So true. We need to slow down, don't we? And I think diabetes, certainly for me, has made me, be more mindful about everything. So I think, you're absolutely right. But it is good to know I can have a bit of watermelon, because I've taken watermelon right out.
Yeah, but it's the same with a lot of those higher GI foods. Yeah. Sometimes it's the amount you eat, and sometimes it's what you're eating it with, or it's sometimes it's just, don't buy a huge banana, have a small banana, or have it with something that's low GI. The other thing to consider with diet is we're looking at all of the fibre particularly the fibre in low GI foods. So we're looking at resistance fibre, soluble fibre, etc. They're all feeding those our microbiome. So the bugs that are in our gut, and we want lots of them. We want a nice population of in our intestine of the microbiota or microbiome, because they help produce chemicals which help reduce inflammation in our body. And there's now emerging evidence which is saying that both type 1 and type 2 diabetes and a lot of chronic conditions are related to inflammation. So by having these higher fibre diets and having prebiotics, these foods are considered prebiotics, we feed these bugs in our gut, and it's healthy for us. Yeah. The other thing to think of, if you want a diet to follow, is to look at the traditional Greek Mediterranean diet. And that's where it's basically lots of vegetables. So there's a lot of plants, there's some fruit, there's some dairy, a small amount of meat, but lots of legumes, some nuts. And in Australia, I'd be recommending Australian extra virgin olive oil as the main oil. But it's not a lot of people think, pasta, red wine and olive oil. It's not that high in pasta, not that high in red wine. No, it's before all the French influence, so there's no creamy sauces or anything like that. And pasta is actually quite a small amount of the diet. So
exactly, yeah. It's hard. It is. You're right. They're one of the things that used to be one of my old faves every now and again. But I think you'll find it gets heavier anyway. I mean, it's just as we get older, it's too heavy. Wow, you had a few things I want to unpack. But anyway, let's move on, because this is not actually a question. Well, I suppose it is, but this is more, I guess, a bit of feedback from one of our group members. And he says, she says in this case, so why isn't it mandatory for doctors to have a set plan to organise at the visit when they tell you about having diabetes? For too many newbies are handed tablets and told nothing. Must be a set of steps to do, such as explain, I haven't edited this, such as explain meds, organise care plan, give a list of healthcare team, etc., i.e. dietitian, educator, podiatrist, endo. So many left completely in the dark from the start. Yeah. How do you feel about that?
Well, the RACGP guidelines actually emphasise that diabetes diagnosis requires a person-centred care. All health professionals try to follow a person-centred care. But in the short time that a GP has to consult with a client, often that gets a little bit overlooked. Yeah. So they should go through those steps.
Yeah.
If they send you off with medication, they should say, make an appointment to come back and we'll sort out a care plan. And they should be registering you for the National Diabetes Services Scheme so that you can get subsidised strips and attend. The Diabetes Queensland runs lots of education programs in Queensland, and the other state-based organisations do them elsewhere, but you need to be registered with the NDSS to be able to attend them.
I've attended a few, actually. I find them extremely helpful. I think, and I guess it was very similar for me. It was finding through the dark. I mean, my GP was quite good, but I can tell you, going to the Diabetes Queensland, Diabetes New South Wales, each one, those getting your educator, they're the ones that need to be your mentor and guide. I found they were incredible, absolutely incredible. Katie is just a gem, as I said. So she's not always easy to get into, but she sets it all up for you, and she answers all the questions. So I'd certainly recommend that for anybody. All right. So what we're going to do, I think. Wow, there's just so much to cover on this topic, but what I think we'll do is we'll go with one more question, and then we'll do what we were talking before. So I guess one of the critical things is, how often should I check my glucose level?
That's like saying how long is a piece of string or how much carb I should eat.
But it's a valid question, right? Yeah. Because, I mean, this is what I'm hearing. And I must admit, I asked the same question.
If you're on a medication that causes hypoglycemia, so any of the insulins or a sulfonylurea family of medications, so that includes diamicron, Amaryl, glycoside, glipizide, things like that, they cause blood glucose to go low. So one is providing insulin, the insulin injections, and the other makes the pancreas work harder. So you're producing more insulin all the time. For those people, they need to check their blood glucose levels frequently. So the GP might guide someone on a sulfonylurea to take it first thing in the morning and then at a regular time. So maybe before meals, once or twice a day. So over the course of the week, if they choose different meals, you get different readings. When they see the dietitian will say, I want to know what your glucose is before the meal and 2 hours after you've started the meal, because that will see if your blood glucose has gone up and come back to about the same, or whether it stayed up or gone to the low. And of course, on those medications, if people feel unwell, they should check their glucose, because they might be hypoing. Things like alcohol, exercise, hot weather, not eating the usual amount of carbohydrate for some reason, all cause hypoglycemia. For everyone else, they're not at risk of hypo. So if they've got an HbA1c, which is in the sort of target range, so around 7% or less, then the GP probably says, don't bother testing. Don't check your blood glucose levels, because you're not going to hypo and you're managing quite well. For other people, if they're a bit more progressed, it might be that they're just interested. They want to see what a meal does to their blood glucose, and that then tells them, okay, I need to eat less of that, or I need to have less of the carbohydrate portion of that. So and you would do it in a targeted manner, perhaps for the week or two before you see your health professional. You wouldn't be doing it every day, because you just you don't need it. It's there for information, but it's not there. A lot of people in the past, they'd do a finger prick, they'd write it down, and they wouldn't do anything with the information. They didn't close the loop in regards to self-management. It was just a number in a book given to the doctor or the health professional once every 3, 6, 12 months. And they'd go, oh, yes, that's nice. No one acted on it. Yeah. So if you're going to check your glucose, you need to act on the information.
Right. Okay. That's actually a really good way of putting it. So, and just very quickly on the percentage. So, what's a comfortable reading in an HbA1c test every quarter?
Well,
I
you're
mean,
looking
obviously,
for
what's
7%.
ideal and what is just within range? So, if you're not diabetic or if you're pre-diabetic, what is your range? And then what is someone who's living with type 2 diabetes? What would be that maximum or acceptable level?
Well,
I'm asking for a friend.
yeah, you want to be under 7% for an HbA1c.
Yeah.
If you're under 6.5, and you're not on medication, it means you probably don't have diabetes.
Right.
So, yeah.
Okay.
But the finger prick is where it gets interesting. Now, we're moving with the HbA1c. Australia is moving from sort of, I think it's from imperial to metric or something. So we're moving from percent to millimole per mole. And that's because people get mixed up between the number they get back with their HbA1c and their finger prick number. The finger prick is measured in millimoles per litre. And so
right.
The number,
vital piece of information.
Yeah, the number that you get for your HbA1c is a percent, so it's not reflective of what the finger prick is. So with your finger prick, there's generic guidelines for people with type 2 diabetes. We're looking, 6 to 8 millimoles per litre, ideally before a meal, and up to 10 2 hours after a meal. Wow. If you're frail and aged and living in a nursing home, you might be looking from up to 15, or if you're not going to be with us for much longer, we're not so worried about high blood glucose because we're not worried about the long-term complications. We just want you to be comfortable. Yeah. Whereas for someone who's young and they've got a lot of years in front of them, your doctor might give you a tighter target. So targets are usually given based on your comorbidity, so what other health issues you've got and what you're managing. So everyone will be given, in theory, a slightly different target range to try and achieve, and that should come from your GP. Yeah. I think that was really helpful because I think that's where a lot of the confusion lies is the millimole, whatever it is, and the percentage. So the HbA1c, just to be clear, is a percentage. So if it's 6.3 or whatever, it's a percentage of that, and that's different. Yeah. Okay. Oh, yeah. That's incredibly helpful. Oh my gosh, I could just talk to you for days. So I hope we get a chance to get you back, but I know we've got some other questions we're going to go through another time. But I want to thank you, Dale, so much for spending the time with us today. As I mentioned, we got inundated with questions for you, so we're going to do that at another time. But thank you so much for joining us. I sincerely appreciate it. No trouble, Lindy. Thank you.